to everyone who joined us today. So is everybody can hear me clearly? So on behalf of the organizing committee, thank you for making the time with us today. It is a very important educational webinar focusing on the cancer care in primary care practice. So cancer care is increasingly become a shared responsibility across multiple disciplines, and primary care provides play a crucial role in early detection, timely referrals, patient counseling, as well as a long-term survivorship care for the patients. So tonight's program is designed to provide practical insight, current perspective, and a real-world approach that can help us deliver better outcome for our patients. My name is Dr. Hanis. I'm one of the general surgery master trainee from Universiti Malaya, and it's my pleasure to be our moderator for this evening session. We have an excellent lineup of speakers from Universiti Malaya and our clinical community as well, who will be sharing their expertise and experience with us. Without further ado, let us begin our session this evening. First of all, it is my pleasure to introduce our big boat and pillar of today's event, which is Associate Professor Dr. Suniza Jamaris. She is a distinguished oncoplastic breast surgeon and academics from the Faculty of Medicine, Universiti Malaya. She has been actively involved in advancing cancer care service, research, and also education in Malaysia. As the principal investigator of the REBUNG project, she has been instrumental in developing initiative aimed at strengthening cancer care pathway and improving coordination between primary care and also specialist care. This evening, she will provide us with the overview and also the vision of the REBUNG Optimal Cancer Care Pathway Program, as well as its role in enhancing cancer care delivery. Please welcome Prof. Suniza.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh, and very good evening to everyone. Thank you very much to Hanis for very kind introduction. I would like to thank to all of you who joined us for tonight. I think some of you might heard about REBUNG Cancer Care in Primary Care short course, but some of you might not know about this initiative. But it's basically this initiative is developed by the Universiti Malaya. So basically to strengthen cancer care in within the primary care settings. REBUNG Care in Primary Care short course is an online multidisciplinary educational program designed for general practitioners and primary care healthcare providers. So our goal is very simple: to improve early cancer detection, facilitate timely referral, and ultimately to improve cancer outcomes in Malaysia. So when we talk about the challenge when we are managing a patient in cancer in Malaysia, is biggest challenge is most of our patients presented late at stage 3 and stage 4. Although awareness has improved, however, our delayed diagnosis is still a common issue, is common problem that we encounter. And what is more worrying is the Malaysian National Cancer Registry alarming trend. You can see in for breast cancer, there is increase a lot more patients presented at stage 3 and stage 4 when we compare with our previous National Cancer Registry. And this is not only in breast cancer. Half of our patients also presented late in a colorectal cancer, lung cancer, as well as cervical cancer. Early diagnosis, as we know, offers many benefits. So early diagnosis, patient receive treatment earlier, experience better survival, better quality of life, and often require less intensive treatment. As you know, the higher the stage, the more morbidity, the more complex in terms of treatment, and also the more the patient will receive a lot more complications, side effect from the treatment, the cancer treatment. So early diagnosis actually been recommended by WHO is an important cancer control strategy for middle income countries without organized screening like Malaysia. We don't have organized screening. So because of this, so we developed a training program to all the general practitioners. So to improve in terms of cancer screening, early diagnosis literacy, in order to improve early diagnosis, early detection. And beyond improving clinical knowledge, we also aim to standardize cancer care practice, strengthen collaboration in between primary care as well as tertiary care. So what we have tonight is a Kanser iECHO, is one of the component of REBUNG cancer care in primary care short course. This is an virtual case-based discussion where we'll have a specialist. That's what we have tonight. We have urologists, we have oncologists, we have family medicine specialists, and all of you come together and discuss. We are discussing the real case-based discussion. And as you can see here, since its launch, REBUNG has expanded not only in Malaysia. We do also have a participant from Indonesia, participant from Brunei as well. So you can see one of the strength of this REBUNG is the community that we created. So you can see this is not only among the surgeons, but it's also among the oncologists, FMS. You know, we sit together, interact together, discuss together how to improve our cancer care in Malaysia. So this is the important thing for the online REBUNG cancer care in primary care short course. As you can see, these are all the weeks, 7 weeks. It's actually 10 weeks training modules. You can see is basically consists of multiple modules. You can covering from cancer, including breast cancer, which is most common cancer in Malaysia, colorectal, cervical, lung cancer, and prostate cancer. As you can see, this is how the program will be looks like. The introduction start with introduction in atrium, and there is week 1 until week 7, which also includes psychosocial, which is very important in cancer care, and also patient navigation. At the end of these REBUNG cancer care in primary care short course, there will be a Kanser iECHO as what we are having tonight. Actually, we already have this year we already have 2 Kanser iECHO that covered the lung cancer, and recently we have closing that we have the cervical cancer together with the palliative cancer. So as the course is delivered through the Universiti Malaya Atrium Learning Management System. You just registered online and then you log in. Once you log in, you will be directed into this REBUNG cancer care in primary care short course. And then you can see these are all the modules in this atrium. You can see each module have the sub-module. As you can see here, there is a Q&A session in between. If you have any question, you know, that related with that specific module, you can just drop your question in Q&A and the educator will reply accordingly. It's very interactive, and actually we have a what you call that gamification, engaging. You can see this is not only a reading material, there is also like drag and drop, you know, the correct boxes. So it will, I hope that it's the participant feel that this is not just reading materials as what we normally have as an online training. Okay, so for the closing event, we have a Kanser iECHO as what we have last year, and then I would like to share with you. I'm honored to share with you that we have we won Awards 2023 Open Learning Global Innovation, and also we won the Merit Awards Best Abstract Submission for this REBUNG cancer care in primary care short course last year. So if you have any question, please email us at rebungselangor@gmail.com. With that, I think I end my overview. So I hope that you understand what is this about REBUNG cancer care in primary care short course. Over to you, Hanis.
Thank you so much, Prof. Suniza. It's a very great achievement that REBUNG has achieved so far. And thank you for the very insightful overview of the program itself. So we move on to our first speaker of the day, Mr. Ahmad Nadzran Fadzli. So he is graduated from University of Leicester, United Kingdom in 2006. He subsequently completed his Master of Surgery in Universiti Malaya, contemplating between cardiothoracic or urology, subsequently obtained board certification in urology, finally making his mind in 2016, and was awarded the Fellowship of the Royal College of Physicians and Surgeon of Glasgow in Surgical Urology 2019. Currently, he's the consultant urologist and also head of the urology unit in Universiti Malaya Medical Center. He has extensive experience in the management of urological condition, including prostate cancer, which is one of the most common cancer affecting the men worldwide. PSA screening remains a topic that often generates questions and differing opinions among the healthcare professional, especially in the primary care setting. Navigating this discussion with patients require both evidence-based knowledge and also clinical judgment. So in his session tonight, Mr. Ahmad will help us for better understanding the practical role of the PSA testing, what does the result means, and how can we apply current evidence in our day-to-day practice, and moving forward, how shall we counsel our patients? So please welcome Dr. Ahmad for the topic tonight, to screen or not to screen, making sense of PSE in daily practice. Please welcome.
Assalamualaikum and good evening everyone. I'm Ahmad from Universiti Malaya. Thanks for Suniza and Hanis for the kind introduction. Hanis, have to be careful. Whatever information I tell you come out on dangerous. Okay, so anyway, so I'm going to share my slide. Can everyone see my slide?
Can Mr. Ahmad?
Can, okay. So I said I'm Ahmad, one of the urologists in PPUM. So I've been given the task to talk about to screen or not to screen, making sense of PSA in daily practice, but also go through a bit about how we diagnose and some of the surgical aspects about prostate cancer. Okay, so I think we'll leave questions to the end. Okay, so prostate cancer, why is it important? As I think Prof. Suniza said, cancer is generally rising in Malaysia, and prostate cancer, I mean, not exactly something to be proud about, but we are number 3 lah. Okay, so in men in Malaysia, okay, giving an age standardized rate of 9.3, rising from the previous national cancer registry. Risk factors, the one that is known is age, and it doesn't apply for us sangat, but mainly is age and family history lah that is important for prostate cancer. Okay, and we always talk about foreigners, Tom Hanks, CTC that had prostate cancer, but actually there's a significant number of Malaysians, whether they be writers or politicians or sportsmen. We have had our share of important people with prostate cancer. And then most cancers, generally, they can be localized as in stage 1 to 2, locally advanced stage 3, and metastatic as in stage 4. So why this will bring up the stage is because you look at this, if you look in other more developed countries like UK, we do not get majority of patients presenting at stage 4. So you can see here, even at the latest cancer registry, the 53.2% are presenting at stage 4. Okay. So this is something that why we're talking about all this screening thing. And of course, that's what Prof. Suniza said. We want early detection because we want there to be a chance for cure. Okay. And of course, the earlier the stage, the less sometimes the less complex the treatment and may lead to better outcome and less side effects. And particularly in prostate cancer, which can sometimes spread to the spine, causing debilitating conditions like paraplegia. So we want to avoid that. And you can see from evidence-wise, 5-year survival for stage 1, 2, 3 is 97, more than 90%. But once you're stage 4, it's more than half, less than the stage 1, 2, 3. And that is the stage where most of our cancers are, in stage 4. But of course, there's another side to the sword. Sometimes you end up treating indolent cancer, which actually may not have caused any problem, and there are significant associated treatment side effects. Okay, so what is PSA, or prostate-specific antigen? So it's protein produced by both cancers as well as normal prostate cells, okay? And it's actually mostly found in semen and a small amounts in the blood. So as like the name says, it's organ specific, but unfortunately, it is not cancer specific. So any inflammation, infection, some say that the DIE doesn't increase the PSA so much, but and a lot of things can raise the PSA, and there's no true cutoff value for PSA. And for now, there's no real validated option now that can replace PSA. So the question, as what it says, should we do or should we not do PSA? Yeah, I think for symptomatic patients, I mean those who have urinary tract symptoms, hematuria, something not quite right, then yes, after discussion with a physician such as yourselves, they can do the PSA. But for asymptomatic, that's the question now. Should we do it? As I said, early diagnosis may give better chance of cure, but may lead to over treatment. And problem is if you do the PSA and somehow you can never diagnose prostate cancer, that can lead a lot of anxiety to the patient. Yeah, and this is what I mean. So PSA, there's no true cutoff value. So even if your PSA is 0, there's still a risk of prostate cancer. We have had young patients, PSA 1 to 2, and they have clinically significant prostate cancer. Okay, so what does the evidence say? So these are the two big trials that are talking about prostate cancer screening. So the PRCO trial showed no survival benefit, as expected increase in the diagnosis of indolent cancers. And whereas the ERSPC study, which just recently published a 23-year follow-up, showed that the number needed to screen to prevent one prostate cancer death is 456. This, correct me if I'm wrong, Prof. Suniza, this is actually slightly lower than that for mammogram. And then the number needed to diagnose to prevent one cancer death after 23 years follow-up is 12. So actually not bad numbers. And a recent systematic review, as expected, showed that screening increases diagnosis of prostate cancer, increased diagnosis of localized but not advanced prostate cancer, reduces cancer-specific mortality, but did not or almost had very little effect on overall mortality. So what does the Malaysian say? So this is actually a guideline that came out by MOH and said for symptomatic patient, that's why the guideline right there is early diagnosis. Symptomatic patient offer PSA if age more than 50, those with family history or BRCA mutation can offer age more than 40. And what do you do once, and this is actually from the European guidelines. So they actually advise if your life expectancy is less than 15, then you don't really need to do that asymptomatic. But they're similar to us, they use a cutoff of 50, but they use a cutoff of 45 for family history. We use 40. And once you have done the PSA, what do you do with it? So if it's quite low level, you can actually repeat only after 8 years. Okay, but if it's borderline, like more than 1 for 40 years old or more than 2 for 60, then you can do an interval of 2 yearly. Okay. Some things you can use, there are a lot of online risk calculator. This one is for the SWOT group. So actually you can use this if you have no PSA result, what then you should do. And also if you have PSA result, what should you do next? Okay. So basically I've been saying things, but they answer the question, should you do PSA or not? Not really. Okay, I think for symptomatic patients, there's no question, but even then also, you need to talk to the patient, for what we call shared decision making, because there is some effect of either diagnosing or causing distress to the patient by repeated PSA reading, but they never can diagnose cancer despite multiple biopsy. We have patients PSA, 10 to 20, that despite no biopsy, MRI, or we still do not diagnose cancer, and that can lead to distress to the patient. Okay, just a brief pathway of how we should go. So, let's say symptomatic, we should assess standard history taking, examination, including DRE, looking at life expectancy. And nowadays, if you are concerned, normally what we do is MRI first, and based on the MRI, then we decide whether to biopsy or not. That's it. If there's no risk factor, PSA less than 10, sometimes we can just monitor first. But if PSA is high, then we go for MRI. Okay. Modes of biopsy. Trans factor is still the commonest done. Okay. But the alternative nowadays is transperineal biopsy. Both can be done in the local anesthesia with minimal risk. But people, particularly overseas, are going towards transperineal biopsy because of the lower infection risk. Staging, of course, we still have the traditional bone scan and CT, and where PET scan is not easily available. These are still acceptable, but I think the whole world is moving towards PET PSMA scanner. And just briefly touch about non-metastatic prostate cancer treatment options include active surveillance, radical prostatectomy, vaginal beam radiotherapy, brachytherapy, as well as watchful waiting and focal therapy. And these are the broad options. So I won't go into too much detail, but active surveillance basically means you're delaying treatment until really necessary to avoid side effects of treatment. Okay. Radical prostatectomy, I'm a urologist, I have to mention. So options, open laparoscopic robotic, depend on which is accessible to you. And normally for low to intermediate risk, but sometimes even for locally advanced patients. The main complications are erectile dysfunction and stress urinary incontinence. Radiotherapy is another common option. I think does not so fit for surgery, but this one I'll let Dr. Jasmin tell you more about it, as well as brachytherapy. And watchful waiting is opposite from active surveillance, where you only start treatment if they develop symptoms. And this is normally those with short-term life expectancy. So it's more like palliative intent. Okay. And for metastatic disease, okay, what mainly is by decreasing the treatment's main aim is to reduce the body's testosterone level, because this act like sort of the fuel for the cancer. So that's why we call androgen deprivation therapy. So surgical means you remove both testes, oophorectomy, and alternatively you can go for injectional hormone treatment. And other things, again, I'll let Dr. Jasmin tell more. The other agents that you can do in combination, such as chemotherapy, novel hormonal agents, and sometimes you also still do radiotherapy in the metastatic phase. Okay. A bit of self-advertisement, but if you'd like to know more about not just prostate cancer, but other disorders, we have a free webinar for GP on the 11th of July. Okay, with that, I thank you for your attention.
Thank you so much, Dr. Ahmad, for your very informative presentation. I was joking with Mr. Ahmad this evening, saying that maybe all men should go for PSA screening, but I think he answered us very clearly and helped us to navigate the complexity around the PSA screening and provide practical guidance that can be applied in the clinical practice. So if anyone has a burning question regarding the PSA screening or anything about the topic tonight, so you can drop your question in the chat box and we will answer it. So we move forward from diagnosis to treatment. So how do we navigate prostate cancer care as a GP? So now we move on to our second speaker, Dr. Jasmin Munchar Elias. She's graduated with her MBBS from Universiti Malaya and is currently a clinical oncologist with the Department of Clinical Oncology, Universiti Malaya. She is actively involved in the management of cancer patients across the continuum of care, from diagnosis, treatment, and planning for survivorship. Her workplace is actually interaction of multidisciplinary cancer management, where collaboration between the oncologists, surgeons, and primary care practitioner is essential to achieve the best outcomes for the patients. So tonight, she will share valuable insight on navigating prostate cancer care from a general practitioner perspective and discuss how primary care providers can support patients throughout their treatment journey. So please join me to welcome Dr. Jasmin.
Thank you so much, Hanis. And I think I have to thank Dr. Ahmad for setting the stage. He has done a really good overview and also introduction to the topic and also leading up to my talk. So I think I have to say the organizing committee has done a great job. I think this is a really good effort in bringing together the community doctors and also the tertiary doctors to improving the treatment of prostate cancer patients. So without further ado, let me start. a bit of disclaimer. I did use a little bit of AI, maybe grade 1, but majority were my own slides. And at the end of the presentation, I have a video of a patient taken with his consent. We will go through the introduction, the modality of treatment, and I think your role in the community to support patients, and lastly, patients' message to other patients. So it's important to understand that every stage of their journey involves you, the community team. From the early detection, of course, when they see you with symptoms, to risk assessment, sending that PSA, and Dr. Ahmad has mentioned on when and when not to do the testing, until timely referral. When they come to us, although we treat them, but they do more often than not do come back to you in your clinic with side effects. And if you are able to recognize the side effects, you are able to reassure and manage and support, and also to recognize red flags when they present to the community clinic and when to call us back urgent. And of course, when patients complete their treatment, it is important for us to collaborate with you for surveillance of their disease and manage their long-term complication, promoting healthy lifestyle. Once they are cured, you are involved in also their survivorship, and patients in metastatic disease, you are involved in palliative care in the community setting. So Dr. Ahmad has mentioned about symptoms. Prostate cancer commonly arises in the peripheral zone. Therefore, some patients are asymptomatic, but if it compresses onto the prostatic urethra, patients can have lower urinary tract symptoms. If it metastasizes, patient can present with bone pain. This is just to illustrate that if cancer becomes locally advanced, patient can have hematuria and acute urinary retention. So when the PSA is high, when imaging is suspicious, we biopsy. What the pathologists see under the microscope is the cancer in the form of Gleason score. And Gleason score ranges from score 1 to 5. And this is how they score from score 1 to 5, and they further grade into the ESOP grade group staging. How we stage, I think Dr. Ahmad has mentioned also, we stage either a combination of CT plus bone scan or a PSMA PET scan. In Malaysia, it's quite common, it's third most common cancer. The ethnicity majority are Chinese. Incidence rate actually rise steeply above 65 years old. The 5-year survival for localized disease is great, it's 80 to 90%, but in metastatic disease is quite grave. It's only about 30 to 40%. And we don't want that. And if patients present with localized disease, they can progress into metastatic state if not adequately treated. These are just to illustrate the states of disease patient can be in, whether in localized or in metastatic. And in metastatic also, they can still be hormone sensitive or hormone resistant. So management of localized disease depends on the patient's life expectancy and their health status, which includes their comorbidities, their physical function, their nutrition, and cognition. Because remember, prostate cancer can present in the elderly as well. And it is a shared decision-making with the patient to decide treatment. In localized setting, we risk stratify them according to the hold on, I think I missed the slide. Yes, we risk stratify them according to 3 things: the T and the N staging, the Gleason score, which the pathologists see under the microscope, and the initial PSA. And I put a red star at the initial PSA because the initial PSA most often time is from the community clinic. And it is the initial PSA that we look at, not the subsequent PSA after they start any form of treatment. So we risk stratify them into low, intermediate, and high risk. And in the low and high risk, there is very low and very high risk. And that's how we discuss treatment. So what drives the prostate cancer? And as Dr. Ahmad had mentioned, it is a very hormonal cancer. It feeds on testosterone hormone, which is the male hormone. And testosterone hormone, we know, comes from the hypothalamic pituitary axis stimulation. From the hypothalamus to the anterior pituitary to the testis, a minority of the testosterone is produced by the adrenal gland. And once testosterone enters the prostate cancer cell, it sits on the androgen receptor here and activates the proliferation of the cancer cell. So when we understand how cancer cell proliferates, we can then understand how it is being treated. So we can block the production of testosterone either by removing the testis, or we can give injection to block the pituitary from releasing luteinizing hormone. We can also block the binding of testosterone onto the androgen receptor, and we can also directly damage the cancer cell DNA using chemotherapy or radiotherapy. So the overview of treatment modality. First, the backbone of treatment is by removing the testosterone hormone, either by taking out the testis or by injection. And as I mentioned, this blocks the stimulation from the anterior pituitary. So what we counsel patient is actually, sir, you might get male menopause side effect. And you can see from the picture, this man just does not feel like himself. He forgets what he says, he loses his hair, he loses sleep, he loses muscle, he becomes central obesity. So that's male menopause. And in the short term, we tell them you can get hot flushes, reduced libido, erectile dysfunction, feeling tired, and as I mentioned, mood and cognitive changes. In the long term, and it's more important for you in the community to watch out for osteoporosis, sarcopenia, metabolic syndrome, because it can all affect the patient. They can have diabetes, hypertension, cholesterol, and in that they can have cardiovascular disease and persistent sexual dysfunction, and that affects their also psychological aspect. And it's important because they might be seeing you more often than they see us. This is just to illustrate the effects of androgen deprivation therapy on cardiac risk factors, where patients can get obesity, high serum lipids, and also associated disease. The second modality of treatment is called androgen receptor pathway inhibitor. It actually blocks the testosterone hormone from sitting on the androgen receptor. And the types can be abiraterone acetate, enzalutamide, darolutamide, and apalutamide. The most common drug we use is abiraterone acetate. And you see the side effects, they're not like chemo. Patient can get high blood pressure, low potassium, high sugars because we give prednisolone, ankle swelling, raised liver enzyme, rash, and feeling tired. Chemotherapy is commonly used in metastatic setting. The chemo we use is docetaxel and cabazitaxel. Patients can get hair loss, tired, vomiting, diarrhea, and I put a red star, febrile neutropenia. It's because febrile neutropenia is one of our oncological emergency. And when patients come to the clinic, if they are on chemo, we have to really watch if they are febrile. We have to refer them to the emergency department as soon as you can. PARP inhibitors is something new, but it's used only in metastatic setting. It's an oral treatment as well. Examples: olaparib, niraparib, and talazoparib. The side effects are lethargy, nausea, and pancytopenia. It's only used if the patient has a mutation in their DNA repair mechanism. Immunotherapy is not commonly used. It is also not relatively new. It has been in the landscape for a few years. It's used in metastatic setting. It's an IV infusion, and we test for a marker called MSI, microsatellite instability. If patient's tumor has very high inflammatory or inflammatory background, then only we will offer immunotherapy, commonly pembrolizumab. And the side effects are inflammation because it sort of primes the body's immune system to attack its own cancer cells. Radiotherapy is something very unique. It uses high energy ionizing radiation called photons to damage the cancer cell DNA. We can use it via external beam, meaning you see the radiation, you see the picture on your left, radiation comes from the machine head there externally towards the body, inside the body, or we can implant brachytherapy seeds into the prostate, and the radiation is emitted from inside the body outwards. And the last radiation therapy is called radionuclide therapy, where we inject radionuclide lutetium-177 to target prostate cancer cells that emits a PSMA receptor. So how radiotherapy works is this is too complicated, but in simple term is that it damages the cancer cell DNA and the cancer dies. So usually we will consent patient, we will scan the patient to plan our radiotherapy. Then we will deliver the radiation. We will always monitor the patient for acute side effects and also long-term side effects. So these are the technique. In the olden days, we use a sort of traditional method called the 2D radiotherapy. But now we have moved away from the traditional method and we use advanced technique called IMRT or SBRT. And you can see from the color represents the dose of the radiation is very focused to the prostate. So just to illustrate so that people can have a feel and understand, this is how we plan our radiotherapy. And you can see the beam comes from the moving gantry surrounding 360 and emits radiation into the patient's body. So side effects can be early and late. In fact, the late side effects can occur years after the patient completes radiotherapy. And it's only related to the region we evaluate. For example, bladder, rectum, bowel, skin, penile bulb. In general, we tell them patient can feel a bit tired when they go through radiation. So the difference between radiotherapy and surgery in terms of side effect is not very apparent. I think radiotherapy patient would have slightly more urinary retention or nocturia and slightly more bowel toxicity, whereas surgery, they don't really get bowel toxicity. So the most important, I think, is your role to support patients in the community. Once you understand what are the possible side effects of treatment, I think it is good that you can reassure patient and also support patient based on the side effect. And remember, some of our treatment actually causes high blood pressure, causes metabolic syndrome. So you can help us by monitoring their blood pressure, their weight, their HbA1c, their lipids, advocate for bone health, look at or ask questions about their mood and cognition, and of course, promote healthy lifestyle. If patients open up about erectile dysfunction, remember ADT, the radiotherapy, surgery can have a risk of erectile dysfunction. There's always a referral pathway to our andrologist in any tertiary hospital. And we have our andrologist in UMMC. And of course, red flags to identify red flags and to refer us urgently. And I'll talk about red flags later in the next slide. The note below is very important. Because testosterone feeds on because prostate cancer feeds on testosterone hormones. So we want the testosterone levels to be low. Please remember, do not prescribe testosterone replacement therapy to patients receiving androgen deprivation therapy for prostate cancer. So what are the red flags? Fever. If patients are on chemotherapy and if they are febrile, they can be at risk of febrile neutropenia when the neutrophil is very low. And that is an oncological emergency. If the prostate gland is so swollen, patients can have difficulty urinating or can have acute urinary retention. If it invades the bladder, there's blood in the urine. If patients have metastatic disease to the bone, they can have malignant hypercalcemia, where they present with bones, stones, groans, and psychic moans. If they have a cord compression, they can say they are weak in both legs, suddenly they can't walk, or very bad back pain, because those are the sites where cancer commonly metastasizes. Or if patient is unwell and you're unsure, I think you can just give us a call to consult. So I asked the patient, what is your message to other patients or the community? And this is what he said. And then lastly, what is your message to other patients?
Other patients always go for cancer marker test. The blood test is important, right? And the other advice is that be careful with your food and be active. But to me, if somebody insists to avoid prostate cancer, you must actually active. But at this age, one can do. So the best is always be healthy as well as be what you call go for regular blood test.
So it's very nice to hear his words. Be active, eat healthy, and go for blood checks. But go for PSA checks as recommended by Dr. Ahmad just now. So with that, thank you. Open to questions.
Thank you so much. Thank you so much, Dr. Jasmin, for the very comprehensive and practical overview of the prostate cancer management. I think it's very important for us and also the primary care practitioner to understand the different management in prostate cancer, because sometimes our patients, when we counsel the patients in the clinic, in SOPD with a very time tight condition, so they are feel pressured, stressed, and shy to ask questions. So they will go back to their community doctors, primary care practitioner to ask questions. Then I think this is the role that primary care practitioner should carry, to actually explain to the patients what is actually they experiencing, what is the treatment they are planned for by the urologist. So if any of the participants have a burning question, please drop the questions at the chat box. And throughout the way, our panel will answer the question in the chat box, but we will also address the question towards the end of our session later. So transition to the panel discussion, which is a case-based discussion. We will now move towards more interactive segments of tonight's program, which is the Q&A session and also case-based discussion. This session will bring together a distinguished panel of experts who will discuss practical scenario commonly encountered in the primary care setting. So joining our panel tonight will be Mr. Ahmad Nadzran, who had discussed with us regarding the PSA screening, Dr. Jasmin, who had just presented to us regarding the management of the prostate cancer. The next speaker would be Dr. Durvesh Jathwani, who is the consultant urologist and renal transplant surgeon at Hospital Kuala Lumpur, which is one of the Malaysia leading tertiary referral center for urology and also kidney transplant service. Dr. Durvesh graduated with his MBBS from AIMST University in 2011 and subsequently pursued advanced specialist training in urology and earning the fellowship of the Royal College of Physicians and Surgeon of Glasgow in urology. We are also honored to have with us Mr. Peter Wong Yupa, a dedicated cancer advocate and also survivor, who brings the invaluable perspective of patient, survivor, and the community to today's discussion. Mr. Peter served as the community member of the Prostate Cancer Society Malaysia and is the treasurer of the Together Against Cancer Association Malaysia, a national advocacy organization committed to improving access to quality cancer care and supporting individuals affecting the cancer. So together, we bring a wealth of expertise spanning surgery, oncology, primary care, patient survivor into the perspective. Moderator for this session will be Dr. Christine Shamala Selvaraj. She is a committee member of the REBUNG Cancer Care and Primary Care short course and also a faculty member of the Department of Primary Care Medicine, Universiti Malaya, and also Dr. Gokilavani Sekarchandran. He is an honorary treasurer of the Private Practitioners Section, Malaysia Medical Association, an experienced primary care practitioner with a strong interest in continuing medical education and also quality patients care. So now I would like to invite Dr. Afika, our General Surgery Master Trainee in UM, to present the case-based discussion, and subsequently our moderators, Dr. Christine and also Dr. Kokilavani, will lead the discussion together with the panelists. Please begin.
Hi, good evening, everyone. So I'll start presenting my slides. So here we have a 60-year-old gentleman. He's a retired IT consultant, ex-smoker, occasionally consume alcohol during teenage years. Otherwise, he has no other medical illness. ECOG status is good, it's 0. So he initially presented with lower urinary tract symptoms, which are nocturia about 1 to 3 times per night, weak stream, and also incomplete voiding. Otherwise, during our clinical assessment, noted that the prostate size is 50 grams. The prostate is smooth with no nodules filled. We did a PSA for him and it was found to be raised 71.8. So subsequently, he proceeded with MRI prostate, which showed suspicious PIRADS 5 lesion and pelvic lymphadenopathy, and there's also suspicious of bone mets. So we took a biopsy for him, and it was confirmed that he has a prostate cancer, Gleason 4+4. He then underwent a plasma PET scan in Beacon Hospital. There was found to be a prostate. It was confirmed to be a prostate lesion with small obturator metastatic lymph nodes and also metastasis to the right 7 and 10 ribs. So further management, he was initiated with androgen deprivation therapy, ADT, followed by enzalutamide since May 2026, and he is also planned for radiotherapy to the prostate and also lymph nodes. So here, the learning point is older men with large symptoms should not be assumed to be benign prostate hyperplasia alone. And a normal DRE does not exclude clinically significant prostate cancer. So a mildly elevated PSA warrants urgent further investigation and also referral. And prostate cancer may be asymptomatic despite advanced metastatic disease.
All right. Thank you, Dr. Afika. So I'll just come back to this case in a while. So good evening, ladies and gentlemen. We've come to the case-based discussion section of tonight's event. Thank you once again to the speakers who gave us a very interesting and informative introduction to managing prostate cancer from the perspectives of urology and oncology. Dr. Afika, can we go to the first slide, please? I just want to clarify something before we carry on. So this is quite a typical presentation that we might encounter either in primary care medicine or even in the SOPD, as you mentioned. So can I just clarify, where was this patient referred to?
So the initial referral was from RUCA, our primary care center, and then initially referred to us for large symptoms to a continuation of BPH. But prior to the presentation to SOPD, patient actually took PSA as well. So we found that the PSA was raised. Hence, we proceed with further investigation.
So the PSA was taken at the primary care settings. That what you're saying?
Yeah, they took the PSA before referral to us.
Okay, good. Thanks. Because the reason I ask is because it does have something to do with some of the questions we are getting. We're getting quite a number of questions in the chat box. So very good. Keep them coming. They're very good questions. So to start off the discussion, I would like to invite Dr. Durvesh Jethwani. Doctor, would you like to comment on the presentation of this gentleman?
Hi, thanks for the opportunity to speak. So, I mean, this is a very classical patient we see day in, day out in our practice. I mean, it would be very easy to say this is a patient with BPH because that's the most common thing that patients present at this age. But the PSA here is alarming, obviously, with the PSA 71. I think what this case highlights is that on a rectal examination, no nodules were felt. And I think often in primary care that we place a lot of emphasis on that finding, when in reality, the sensitivity of a rectal examination is in question. So I think it's quite reasonable that the PSA was done. It's very unfortunate that it was high. And I think it'd be interesting to see how long this patient actually had the symptoms for. But we know that prostate cancer itself actually doesn't always present with symptoms. So it's mostly asymptomatic. So this man probably got diagnosed with late stage prostate cancer with incidental finding, really. And the BPH symptoms were probably what actually brought him in. So it's an example of why screening is quite important in this group of patients.
Thanks, Doctor. I think very often some of the challenges we face in primary care medicine, of course, we do deal with a large number of patients on a day-to-day basis, but I think many of us in primary care medicine struggle with the conversation to have with the patient before a PSA is taken. For example, in this case, without looking at the PSA, you might think, he might be just someone who's coming in with BPH, and cancer might be, we would think about it, but it might not be so high on our list. So would you mind sharing how you'd have that discussion with the patient before taking a prostate-specific antigen test?
Yeah, I think Mr. Ahmad alluded to this in his response to
Yeah.
someone in the chat. And it's very succinct and concise. I quite like his answer. But simply put, I think even in BPH, PSA has a role. It's not just for prostate cancer screening, it's also for monitoring the disease and risk stratifying these patients, and helps us decide what medication to start these patients on, what treatments to offer BPH patients. So even in BPH patients, PSA definitely has a role. And so these patients are the symptomatic patients. They're not necessarily looking for prostate cancer symptoms, but BPH symptoms as well. So I think if you have a BPH patient, it's very valid to offer a PSA test. I think there's a debate as to whether this is still considered screening because they're symptomatic. It's more part of the treatment pathway for BPH. The conversation of anxiety, I understand. I've had patients who are crippled by anxiety, but mostly in the West. I don't really see this in our Malaysian population. And as the start of this presentation, we've seen that more than half of our patients are still presenting in late stage prostate cancer. So I think you can reassure them, because I think the things we do now have also changed. So screening for prostate cancer does not permit everyone to overtreatment. I think that's changed a lot in the recent past. We now employ a lot more active surveillance and minimally invasive treatments, and I think we include imaging before we put a patient through a biopsy. So I think there are a lot of things that have changed over time, and I think that the PSA is quite important in patients with BPH. And I think that anxiety can be mitigated. You just have to tell them that, look, it may be elevated, there may be other causes. It's prostate specific. And again, it's not cancer specific. And there are other tests that we need to do to confirm. And then send them to a urologist, because I think that's what we need to do next.
Thank you very much, Dr. Durvesh. Dr. Afika, can we go on to the later part of the presentation with regards to the management? Dr. Durvesh or Dr. Ahmad, do you have any comments with regards to the management? I mean, from what I can see here, treatment was started relatively early for this patient. I don't think there was much of a delay, but sometimes there might be different circumstances with patients coming from perhaps other parts of the country, and where they might not necessarily be able to present so early. Do you have any comments with regards to the management?
Divek, you want to go first?
I think it is pretty standard, an MRI and biopsy. I mean, in this case with a PSA of 71, I do often tell patients you don't really need an MRI. The chances of finding clinically significant prostate cancer is quite high. But the radio oncologist will probably still want an MRI for staging and for planning.
Right.
If this turns out to be localized prostate cancer, because sometimes you do have high Gleason score prostate cancers that produce such high PSAs and are still localized disease. So I think this was quite reasonable, and I'd say pretty close to gold standard. I think in the West, people move towards PSMA upfront, which again is an area of debate, and where money is infinite and resources are infinite, then that's probably a good idea to go for. But I think this is quite standard.
Yeah, I agree with Divek. I think the pathway is quite there, and picked up on screening, and then I agree with Divek 100%. Particularly if the PSA is more than 40, sometimes we will, because you don't want to delay treatment, that we do biopsy first. But in this case, I think the MRI was done quite fast, so I don't think there's any delay. And it will help our planning, particularly Dr. Jasmin want to do radiotherapy for the prostate, the one the MRI will be helpful. And definitely ADT is the backbone of treatment, and ENZA is one of the androgen axis androgen receptor pathway inhibitors that is a standard of care. So I think I agree with the treatment.
Thank you, doctors. Dr. Jasmin?
I agree. I mean, for us, the MRI is really important because
Yeah.
because you remember the picture I showed. I mean, the prostate sits very close to the rectum and the bowel and the penile bulb. So if we sort of miss the target, they get more side effects. So it's really important for the MRI.
Yeah. So with respect to for you to institute your treatment, yeah. Okay, that makes
But the
sense.
issue with MRI is that in government, I think still less than 10 hospitals have a 3 Tesla MRI. So that's the issue about MRI.
Yeah. So we hope that will, improve with time. Hopefully, fingers crossed. So, we are very fortunate to have Mr. Peter Wong with us, who's a survivor. I believe. I think we're all interested in listening to your experiences and perspectives as well, Mr. Peter. Are you here?
Okay. Can you hear me?
Yes, I can, Mr. Wong. Thank you. Yeah.
Yes. Okay. What do you want to hear about from me?
Well, when you look at this case, would you say, I mean, how does your experience compare to what we've seen in this gentleman here? Could you tell us about how you found out, how you were diagnosed, and a little bit about your own personal journey?
Great. All right. At the age of 60, I had this urination problem at night. For me, I thought, well, getting at this age, it is something quite normal. But then, a few months later, I would say I was quite fortunate. My son graduated as a doctor, and he was posted to Klang Hospital. And he said, "Daddy, why don't we make a full blood test for you?" Well, reluctantly, I agreed. And then he told me, your PSA is 36.4. How do you feel? So I said, what do you mean how I feel? I don't feel anything. So being a doctor, he asked me, how is my relationship with my wife? I said, well, I slow down a bit. At night, I need to go urination 3 to 4 times. And then he said, "Daddy, it's not normal." I say, "What do you mean not normal?" "Yeah, your PSA is so high. It is above 4. "Oh," I say, "so what is that?" Anyway, they gave me a reference letter to HKL to do a second opinion. Well, the result was the same. So that year was 2008 in the month of May. I did the follow-up, did all the practical MRI, CT scan, things like that. And then Euro, put the finger inside, and then he said, blah, blah, blah. And this, I didn't know what it was, what they were talking about, Gleason score, PSA, and all that lah, at that time. Okay. So Euro didn't treat me. They put me over to oncology department. And there I had done 35 rounds of radiotherapy and followed by 2 years of Zoladex. Everything came down to 0.01. Yeah. But then in that period, going through the radiotherapy, oh boy, it was a really tough time. It was a tough time. Yeah. I had to be running always looking for toilets, couldn't stay still in a place. Yeah. Yeah. Anyway, after that radiotherapy period, things got a lot smoother. And then I had a very good honeymoon period until 2020. That means about almost 12 years. Yeah. And then the PSA started to rise. And that was also during the period of the COVID. We can't really go to hospital. No, they don't really want to see us. So anyway, it rose up to almost 20. Then I had the first opportunity to go back again, and then they gave me another round of Zoladex. It came down. Today, 2026, I'm hovering around 0.24 with intermittent Digarelex injection. Yeah, because I had one stent in my heart 2 years back after my marathon running of
Oh, wow.
21 km.
Wow.
Yeah.
Brilliant.
Yeah, I think exercise is so important.
Yeah.
You know, you've heard of ESG. It is an exercise support group at the University Hospital. Yeah, that is a group.
Sure.
I was the president for 9 years, and I was really into exercise.
And what sort of
Yeah, and
exercises did you used to do, Mr. Wong?
we have strengthening exercise.
Yeah.
We have Zumba dancing. We have aerobics, and we have a mini boot camps in the hall also. Yeah, we are all cancer survivors, and there are a few what we call caregivers as well.
Okay.
And for the information, I've done Mount Kinabalu 3 times successfully. Yeah, that is the power of exercise. You know, I really want to keep myself fit. And we have planned for next year, May 22nd, 2027, for another round of Mount Kinabalu, number 5.
Right.
Yeah,
Excellent.
going. Yes.
That's really inspiring. And I totally agree with you, Mr. Wong, about how important physical activity is, especially with respect to, as you mentioned, strength training on top of your usual cardio and balance training. But yeah, it's really inspiring to hear your story. But we will come back to you in a bit, Mr. Wong and the other panelists. Do you have any questions for Mr. Wong, doctors? Dr. Jasmin, Dr. Ahmad, before we go on to the next case?
Not really. Thank you.
I just need to look up the ESG. I really need to join and advocate my patients to join as well. Really good initiative.
Oh, yes, please. Yes, please. Please let me know if you have patients or if you are in contact with Prof. Naha of a University Hospital. Yes, Prof. Naha, the dancing doctor.
Dancing doctor.
Yes.
Yes,
Prof. Naha
yes.
is our sports medicine specialist.
Yes.
Yeah.
Correct. Sports medicine. Correct. Yeah.
Good to see you, Mr. Wong. Good to see you.
Yes.
That's great. All right. Thank you, everyone. Please keep those questions coming. Thank you, doctors who are answering in the chat box. So without further ado, what we'll do is we will carry on with the second case, and we will also continue our discussions here. Over to you, Dr. Vani.
Very good evening. Firstly, thank you to Prof. Suniza and Dr. Christine for having me and the Malaysian Medical Association at our session this evening. Once again, thank you. Great talk by Dr. Nadzran and Dr. Jasmin. Dr. Jasmin is a very dear friend of mine. We worked together a few years ago. So it's nice to see her speak as a clinical oncologist this time. So proud. And thank you, Mr. Wong. You've actually inspired me to get up early tomorrow and make sure I go to the gym. So I was contemplating, but now I have zero excuse. So there you go. So the next case, we'll move on to the next case. Will someone else be presenting, or shall I carry on with the presentation?
Dr. Afika, would you like to?
Yeah, sure. We can move on to the next case.
Thank you.
So the next case is a bit different as compared to the earlier case. It's a 75-year-old male, ECOG 1. He's a retired government servant, non-smoker, non-alcohol consumer, no family history of malignancy. His underlying illness is ischemic heart disease on Plavix. So for this patient, he was found to be asymptomatic, but noted that he has an incidental findings of raised PSA during his routine health checkup. That time the PSA taken was 42. So referred to us, we did a biopsy and confirmed to be a prostate CA, and subsequently had a PET scan as well. The PET scan found that he has a metastasis to right external iliac region and bone metastasis as well. Otherwise, he also had a lesion in the lungs and cystic lesion at the pancreatic head. So we had an MDT discussion for this case, and consensus was a high volume prostate cancer with lung metastasis. Treatment given for him is a combined therapy, ADT, and also androgen receptor pathway inhibitors, and KIV to counsel for systemic therapy as well. Otherwise, for the pancreatic lesion, refer to HPB for further workup with tumor markers. So learning point here, prostate cancer can be detected incidentally through PSA screening even in asymptomatic patients. Elevated PSA warrants further evaluation regardless of presence or absence of urinary symptoms. And PSA screening and early detection can identify clinically significant prostate cancer before the symptoms develop.
Thank you, Doctor. So my first question is to Dr. Nadzran. Given the number of questions that we got about when to do PSA screening, in this patient, the PSA was picked up during a routine health screening and he was asymptomatic. What's your view on opportunistic PSA testing in asymptomatic men over the age of 70? This patient was 75. And given that this case actually turned out to be a high volume metastatic disease at diagnosis.
That's a good question. I mean, generally, the advice is for patients who have a life expectancy of less than more than 15 years to do, but that of course sometimes is difficult to predict. So in the end, I think we won't like say that, you 75, if you want that we will tell them that cannot do like that. I think in the end, again, comes down to shared decision making with the patient to see whether he wants to do it or not. Of course, on this side, you can see the advantage of doing it because you had somebody asymptomatic, you found had quite significant stage 4 prostate cancer. But of course, on the other side, you have the patients who have a marginally raised PSA and are forever worried why I got PSA, but I do 3 biopsies, still cannot detect any cancer. So that's the other side of the coin now. But in this case, definitely I agree. This shows the advantage of screening.
So I guess the takeaway from that is ultimately comes down to you as the family physician looking at the whole patient as a whole picture and having that shared decision making with the patient to see what outcome we can achieve. The second question again to you, Dr. Nadzran. Given that our attendees are all primary care physicians, are there any other red flags apart from the ones mentioned during the presentation that primary care physicians should prompt early or more urgent referral, given that they may be asymptomatic until it's truly advanced? In your experience, what have you seen?
You mean that referral because of raised PSA or your
No, other red flags that they can look out for.
I mean, the problem with prostate cancer, I think as alluded by Dr. Jasmin, is that there's no real particular symptom. It's not like, for Suniza, you have a breast lump, you think of breast cancer. Unfortunately, we can't really complain of prostatic lumps. So the thing is that simple thing like not feeling so well, losing some weight, back pain, which is very common in the elderly age group. So sometimes the symptom is not so easy, but there are particular, as you said, some particular red flags that should warrant. One is hematuria. So you have hematuria, whether it's microscopic or i.e. only on the urinary or microscopic, you should consider particularly with not visible frank hematuria. The other thing is that if you have patient that we did a digital rectal exam and it's a nodular prostate, so even if it's hard nodular prostate, even if the PSA is normal, I think you should warrant an urgent referral. And if you see other things, like patient, so got other things like, Dr. Jasmin mentioned symptoms of metastatic disease, bone pain, bilateral lower limb weakness, symptoms of hypercalcemia, anything that you feel could be a sign of metastatic disease, also you should be referring to us. as well. For example, I can give two extreme example in the court at the moment. The patient presented journey unwell and then found they actually have a lump having a feeling of bloatedness and then suddenly found to have PSA 200, found to be something else completely. Again, not specific symptoms. So it's I said difficult to point exactly one symptom, but anything quite significant, especially hematuria, or if there's another thing, if there's a significant family history of prostate cancer, then you should refer urgently.
Thank you, Dr. Nadzran. My next question is to Dr. Jasmin. Dr. Jasmin, this patient is on Plavix for ischemic heart disease. So when a primary care physician looks at this case and looks at the medications their patient are on, is there a need for us to liaise with cardiology regarding his continuation of Plavix, especially if you're going to consider systemic treatment like chemo?
That's a really good question. Before that, hi Vani, really nice to reconnect. I think most of the time it's very common because patients diagnosed with prostate cancer are at the age where they do already have metabolic disease, IHD, diabetes, hypertension, cholesterol, and they're most commonly on Plavix, aspirin, Plavix, etc. So when we assess patient, and as I mentioned, the backbone of treatment is to deprive the patient of androgen deprivation therapy, and that itself carries a risk of heart disease. So when we assess patients, we will also assess their cardiovascular risk. And if we feel like the risk is high, let's say triple vessel disease or very recent heart attack or very recent heart issues, then we will refer to cardiology and we will get a baseline cardiac clearance. But I think it is also important for the community doctors to take note also if patients are on ADT plus the ARPIs or plus the chemotherapy and they already have ischemic heart disease, it's just to watch for that symptoms like, chest pain, difficulty breathing, or tachycardia, things like that, where it's just to click that, oh, we have to watch out for heart attacks or a non-STEMI, STEMI, unstable angina, and to refer to the hospital urgently. But I have to say, when I was in training a few years back, and I was seeing a patient similar like this case, an elderly gentleman does not have heart disease but has all the metabolic syndrome, and he is on ADT, and he came and he said, doctor, a few weeks ago I feel very, very breathless when I'm climbing the stairs, and I went hiking and I feel very breathless, and it's just gut feeling to refer to emergency. And it turns out that he has a non-STEMI and he had to go for not semi-urgent PCI. So is that awareness, because the eyes don't see what the mind doesn't know.
So I guess that's a really good takeaway message today. So the next time, I guess a lot of the family physicians here will never forget that when they are on ADTs, think of the heart. Yeah, especially when they come in with those symptoms. But in saying that, like our patient in case 2, how often should a GP follow them up while they're on treatment with you as an oncologist? Should we catch up with them on a 3-monthly basis, monthly basis? What's your advice?
That's a tough question, actually. I think when we look at the international guidelines, for example, the European Association of Urology, I think they didn't specify a fixed regime of how frequent to monitor and what tests to monitor. But the general recommendation is to continue monitor in the community according to local practice, means according to what you are able to. Let's say a 3-monthly basis or a 6-monthly basis, just to screen for diabetes, cholesterol, hypertension, and maybe just to make sure they are on calcium tablets or check their vitamin D levels and advise for strengthening exercises. So I think no strict guideline, as much as you can, or as much as you can cope.
Thank you, Dr. Jasmin. Is Mr. Peter still with us?
Yes.
Yeah. So just from your experience as a patient, did you have a family physician who was following you up throughout your journey battling cancer?
Family doctor.
Yeah.
No,
For a doctor.
it's always the onco or uro since 2008 on my prostate cancer.
Okay. But do you, if you don't mind me asking, did you have any other underlying conditions like diabetes or blood pressure or cholesterol?
Diabetes, no. The heart, yes, I had one stent. BP lah, that's it. And that's it lah.
Who was
No
managing
cholesterol.
who was managing your blood pressure and your heart condition at the time?
Nobody. Oh, okay. Yeah. When I was in EPO, I had what you call I had a blackout in EPO. That was many years, 2006, correct? 2006, yeah. And they did what do you call it? They poked something inside the tie to the heart to do some what do you call it? What procedure you call it?
Angio?
Angiogram. They did an angiogram, correct? Yeah. After that, I was on medication for my heart medication since then. Now HKR has taken over.
Okay, so you've been under specialist follow-up through and through.
Hello?
So you've been under specialist follow-up through and through. So I guess we lost him, but that's okay. I guess the point.
Yes.
Thank you, Mr. Peter. So I guess the point we were trying to get at was like, what are patients' follow-ups like in the community? And given our primary healthcare setting, we are very unique in Malaysia. We have a completely private setting and also a government setting. So patients could be followed up either by Klinik Kesihatan or Ruka at PPUM or even a private GP clinic. But I guess that's where Dr. Jasmin said earlier, the whole MDT coming together, wherever you're from in primary care, having that access to communicate.
Connection not good, huh?
Is the key. And on that front, Dr. Jasmin, Dr. Nadzran, are you aware of any, in what way do primary care doctors, like myself, I'm a private GP, how can we communicate with your team effectively?
The Ahmad?
I mean, normally, most of the time, if the most common that if it's something not like very urgent, you can normally accept referrals from when they come to the clinic. And then normally once they come to the clinic, then they'll be triaged according to the urgency. Of course, if something urgent, then I mean you can always refer. We have an on-call team, so you can call us if it's something urgent, you can call us, the on-call team, and then we can deal with it necessarily through A&E or not. The other thing, I think for UM, we have this website, Beat Prostate Cancer, as well as on social media or not. So that's another avenue that you can get in touch with us nowadays through the website. So I think that one is, I think even Prof. Suniza is there, so that just for the Beat Prostate Cancer.
Yeah. I think as Dr. Ahmad said, if it's urgent, or actually if you're not sure if it's urgent or not, it's a simple phone call to the on-call doctors. And I remember when I was training, we do get from time to time from Klinik Kesihatan, the doctors in Klinik Kesihatan, we're not very sure about patients' previous medication and in relation to the symptom that they're having now. They just call us, and we're okay to look at the details on EMR and just to give our opinion over the phone.
Thank you, Dr. Jasmin. And now we'll move to more technical question. Maybe Dr. Durvish can answer these questions. Dr. Durvish, since this patient presented with a metastatic disease at diagnosis, is radical prostatectomy off the table entirely, or is there ever a role for local prostatectomy?
I think it's off the table. The morbidity associated with the surgery, I mean, it's a pretty safe surgery, but the side effects that you leave a patient with I don't know if there's any role for. I think there's a recent study that came out with apalutamide, adjuvant and perioperative apalutamide. But I think the current answer is still no. Wouldn't offer a prostatectomy for a patient with metastatic disease. I think that's an easy answer.
Thank you. And
Mr. Nadzran might have a different opinion, but I see thumbs up.
Yep, agree 100%.
Any specific surveillance that you, the surgical team will recommend for the GP to do in terms of symptoms such as urinary retention or hydronephrosis risk in this patient?
You're talking about a post-operative patient?
The patient that is going, this particular case actually, when he's going through the this treatment.
Okay, so this patient received systemic therapy. I don't think he received any local therapy because he's high volume. So generally, the urinary tract is unaffected by the systemic therapy. In fact, actually, you may find that some of the LUTs improve once they start on androgen deprivation therapy, but because sometimes the prostate volume also comes down. So the BPH symptoms sometimes actually improve after starting ADT. If someone underwent radiotherapy, then you'd be worried that they develop urethral strictures or even hemorrhagic cystitis. So these are things the oncologist is going to be very upset I said that, but the risks are still there. But yeah, these are things that you can watch out for: worsening LUTs and blood in the urine after radiotherapy. But if no radiotherapy, no prostatectomy, it's just systemic therapy, actually you'll find that the LUTs kind of improve. Except in very locally advanced cases where the prostate just still grow or causes kind of obstruction. In progression of disease, you also get prostate cancer that obstructs the ureters above the bladder. So they may not even have LUTs, but they may present with obstructive uropathy. The lymph nodes can cause compression. So a simple thing like following up with renal function will give you a clue as to these.
I echo what Duvesh said, but generally, particularly this is a quite high volume case. High volume mean significant high volume in terms of the metastasis. Normally, you'll be follow up quite closely. I mean, of course, oncology with the main player, but normally, if there's any issue with LUTS, we do quite often, communicate with each other and treat the patient as a whole. So normally, it's very rare that such patients will not be on close follow up from our side. What do you think, Jasmin?
Yeah, am not upset about the side effects of radiotherapy because they do happen, and they do happen very commonly during the treatment and just a few weeks after. In this patient, if he was symptomatic of the prostate disease itself, we might also offer palliative radiotherapy, and it can get a bit worse during treatment. If they are on active treatment, we normally see very, very often. And as Dr. Ahmad said, we are like a phone call away from each other. But sometimes, true enough, sometimes they do go back to the community doctors, and it's very important for the GPs to also know what to expect and when to refer back to us.
Thank you, Dr. Jasmin, Dr. Duresh, and Dr. Nadzran. So we have 5 minutes left before our session ends today. So I'd like to welcome back Dr. Christine. So we could do the takeaway messages. So while I have Dr. Jasmin just now, if each of our speaker could give us one takeaway message that is really important for GPs not to forget, what would it be? We'll start with Dr. Jasmin.
Can we start with Dr. Ahmad first, please?
Oh, sure, of course.
Alphabetical order, yeah.
Always ladies first.
I would say to see patient as a whole, meaning not very focused on one aspect. And as I mentioned, the side effects is really holistic, from psychological, from the physical symptoms that they feel, from emotions, and what my patient just now, his message to the community is just so important. Eat well, be healthy, exercise, and send for that PSA testing. So that's my message for tonight.
From my side, I think we can't do without PSA lah. It's not perfect. Definitely, there's a lot of flaws to it, but something that we have no choice, particularly as our incidence of prostate cancer is steadily increasing. So I think as long as the patient fully understands what it involves in doing a PSA test, I think it should be offered particularly for all symptomatic patients, but also any asymptomatic patient that understands about screening of prostate cancer. Okay, because early treatment definitely is beneficial. Dubesh?
Yeah, I think I echo that as well. Primary care is the gatekeeper here. Referring a borderline, highly suspicious patient, I think no longer dooms them to a biopsy and things like that. It unlocks, in fact, I think some non-invasive imaging and gives the patients options. I think we are moving forward and we're seeing that in long run that there is some benefit to screening. So and in our country, at the end of the day, we still have a lot of patients presenting late stage. So I would say if you're worried and talk to the patient, just do a PSA test. It's fine, and then you can send them to us to handle the rest.
Dr. Christine, do you have anything else to add?
Nothing more from me. Maybe Mr. Peter Wong, do you have any closing remarks to convey if you're here, Mr. Wong?
Yes. Yeah, as a patient, we often hear that cancer is a death sentence. But I would say a cancer patient who stays in the home is a death sentence. So I would urge all patients to go out, go for hiking, go for walking, go for running, get out, get involved, join support groups. That is my message to all patients. And doctors, please tell your patients that also. Join ESG. Thank you.
Thank you very much. Thank you. Very powerful message indeed. So, yep, so we've come to the end of our case-based discussion session for tonight. Thank you very much to our esteemed panelists for answering all the questions in the chat box here, and I think we've had a great discussion so far. Thank you to all the participants for all your questions, and I hope we can all keep in touch next time. Thank you very much, and we'd like to hand it over back to our MC. Thank you, Dr. Hanis.
Thank you so much, Dr. Christine. Thank you to all the panelists and also moderators and also Dr. Afika today for a highly engaging and also enlightening discussion. We also extend our appreciation to all our participants for all the thoughtful questions. It is very active interaction between the participants and also the panelists. So the exchange of experience and perspective tonight truly highlights the importance of collaboration of cancer care between the specialist center and also the primary care. So before we end our session tonight, I would like to invite Professor Suniza again to introduce the upcoming REBUNG Cancer Care in Primary Care Short Course 2026. This initiative aims to further empower primary care practitioners with a knowledge and also skill necessary to provide effective, coordinated, and also patient-centered care cancer. So please welcome Associate Professor Dr. Suniza Jamaris to introduce on REBUNG Cancer Care in Primary Care Short Course 2026.
Okay, thank you very much, Hanis, for inviting me to just introduce our Kanser iECHO. I would like to thank also to all of our panelists, with very interactive, engaging, and then the case-based discussion that been provided by Dr. Afika. So here you can see in a Kanser iECHO and REBUNG CPC for 2026, we already completed the class A. So they already gotten their CPD points. 20 CPD point is best for to renew your APC. So as you can see, we are already at the Kanser iECHO 3 prostate cancer tonight, and we have next will be REBUNG Cancer Care in Primary Care Short Course Class B, where we are going to start in on 5 of August until 7 October. So you have ample time to finish all the training modules. And last but not least, since it's in October, we take that opportunity to do iECHO on breast cancer. So these are the registration fee. Is not expensive at all. I think 200 for 20 CPD point, and is at your own anywhere at your own pace, you know. So I think is okay. I don't know. I think is feasible for most of you can register. And then for REBUNG Class B, the registration is made until 29 of July. If after 29 of July, it will be 250. Otherwise, before that, you can pay. I mean, the registration early bird will be 200 ringgit. So these are the testimonials from all our participants. Is very wonderful feedback, as well as whatever that we can actually improve our REBUNG cancer care in primary care short course. So I think if you are interested to join our Class B REBUNG care in primary care short course, please snapshot our QR code here, and then you can register accordingly. I think